Welcome back to another All About RX explainer. Okay, let's dive right into this exam-focused breakdown of the lower limb. We have a ton of ground to cover today. Literally.
We're taking a top-down anatomical journey today. We'll hit the introduction to the lower limb, the gluteal region and thigh, mechanics of the leg, anatomy of the foot, compare the upper and lower limbs, and finish up with some high-yield exam recall.
So what exactly is the lower limb? Well, it's the region of your body specialized exclusively for weight-bearing, posture, and locomotion. Unlike the upper limb, which evolution basically designed for precision so we can manipulate our environment, the lower limb is a structural powerhouse built for integrity and moving us powerfully through space.
Section 2. Gluteal region and thigh. The pelvic connection.
All right. Connecting the lower limb to the pelvis, we have the gluteal region. The primary skeletal structures here are the hip bone and the femur. Muscle-wise, you've got the heavy lifter, the gluteus maximus, which completely drives hip extension. Then the gluteus medius and minimus step in for stabilization and abduction when you're walking. But the real star of the show? The sciatic nerve. It's actually the largest single nerve in your entire body.
And that brings us to a massive clinical pearl. The sciatic nerve exits the greater sciatic foramen directly below the piriformis muscle. Why does this matter for your exams? Or, your future patients? Because if that piriformis muscle spasms or gets tight, it compresses that massive nerve. We call this piriformis syndrome, and it completely mimics the radiating agony of true sciatica.
Now, what's really interesting about this breakdown is how beautifully logical the thigh is when you organize it into 3 mechanical compartments. The anterior compartment holds your extensors, like the quads, and they're all powered by the femoral nerve. The medial compartment has your adductors, supplied by the obturator nerve. And the posterior compartment houses your flexors, the hamstrings, driven by that massive sciatic nerve we just talked about. It's honestly a perfectly organized engineering schematic.
To help you lock in the anterior compartment's primary muscle group, the quadriceps femoris, here is a major memory anchor. Just remember, really strong, vast machine. That stands for rectus femoris, vastus lateralis, vastus medialis, and vastus intermedius. Keep that mnemonic in your back pocket for test day for sure.
Section 3. Mechanics of the leg. Mechanical levers.
Moving down to the leg, and actually, scratch that. Let's be precise here. In anatomy, the leg strictly refers to the area between the knee and the ankle. Just like the thigh, it's divided into compartments with very straightforward mechanical actions. The anterior compartment dorsiflexes the foot, meaning it points your toes up. The lateral compartment everts the foot, turning the sole outward. And the posterior compartment plantarflexes the foot, pointing those toes down like a ballerina.
Let's anchor that spatial understanding with an incredibly useful mnemonic from our All About RX guides. Just remember the letters DEP. Dorsiflex is anterior, evert is lateral, and plantarflex is posterior. If you can remember DEP, you can intuitively map out the actions of the lower leg without ever second-guessing yourself on an exam.
So the crucial point is how this translates to clinical trauma. Because the anterior compartment handles dorsiflexion, an injury to its nerve supply, the deep fibular nerve, results in what's famously known as foot drop. The patient literally cannot lift their toes upward during a stride. A highly tested common cause for this, a fracture right at the neck of the fibula where that nerve wraps around and is dangerously exposed.
Section 4. Anatomy of the foot. Ground contact.
7. That is a very important number for the foot. While the human hand has 8 carpal bones, the hind foot and midfoot contain exactly 7 tarsal bones. These interface with your 5 metatarsals and 14 phalanges to create a dynamic, incredibly supportive platform.
Remembering those 7 tarsal bones can be a huge headache, I know. But let's use another awesome mnemonic to lock it in. Picture a group of young zoo animals. Tiger cubs need MLIC. That stands for talus, calcaneus, navicular, medial cuneiform, lateral cuneiform, intermediate cuneiform, and the cuboid. Keep that image of the tiger cubs in your head, and you'll easily be able to reconstruct the foot's architecture. All of those bones, working along with a complex network of ligaments and the plantar fascia, serve 3 mechanically perfect functions. First, weight transmission, from the leg directly down to the ground. Second, vital shock absorption, heavily reliant on those plantar arches. And third, dynamic stability, constantly adjusting your balance during every single phase of your gait cycle.
Section 5. Upper versus lower limb, a comparative view.
To truly master anatomy,
Rote memorization is tough, but contrasting structures makes things stick. And this brilliantly illustrates the evolutionary trade-off we've made. The upper limb is beautifully designed for mobility and precision, utilizing the lighter humerus, radius, and ulna. Contrast that with the lower limb. It trades that wide-ranging mobility for immense stability, weight-bearing power, and locomotion, relying on the massive femur, tibia, and fibula.
When you map these out side by side, it is an absolute goldmine. You can see how the ball and socket shoulder joint directly mirrors the hip, and how the hinge elbow mirrors the knee. It also perfectly aligns the major arterial flows, like the brachial artery in the arm versus the femoral artery in the leg, as well as the key nerves governing each region. This is exactly the kind of structural overview that ties the whole body together.
Section 6. High-Yield Exam Recall, Pitfalls and Pearls.
All right, let's rapidly hit these crucial clinical correlations for ultimate exam readiness. When you see a patient with foot drop, you must immediately think of a deep fibular nerve injury. Compare that to the upper limb. A wrist drop means radial nerve damage. A claw hand points to an ulnar nerve issue, while an ape hand indicates median nerve trouble at the wrist. And never forget those core anatomical superlatives. The largest bone is the femur, and the largest nerve is the massive sciatic.
We've covered the mechanical genius of the lower limb today, but as any anatomy student knows, it's not without its design flaws. Which leaves me with a thought-provoking question for you. If an evolutionary shift to bipedalism gave us the massive weight-bearing femur and the incredibly stable pelvic girdle, what future biological adaptations might save humans from the modern curse of a compressed sciatic nerve? Think about that as you review your notes. Thanks for joining me on this AllAboutRx Explainer, and keep focused on your learning.